It's an honor to stand in front of you today to discuss with you from the Ministry of Health perspective what it will take for us to scale up level 2 newborn care. And I'm glad that I'm doing this presentation after the experience has been shared by Dr. Kathy. I think it has made my work a little bit easier. And I want also to appreciate my other panelists who are going to speak after me for this great time that we have taken off to discuss with you what we need to do collectively in order to improve newborn care in the country. So this has already been discussed. Like you're aware, we have had challenges over years in terms of reducing newborn mortality. Although over the last 5 years we made some progress where we were able to have a reduction of about 18% from 2016 to 2022. However, the journey is still long for us in order to achieve our 2030 targets of reducing newborn mortality to 12 per 1,000 live births. And as you can see from that slide, newborn mortality contributes significantly, over 40% of all under 5 mortalities. So for us to be able to significantly reduce child mortality, we are supposed to collectively work together to reduce all deaths that are happening within the first month of life. We saw this yesterday from the annual MPDSR report, that again we have made significant strides in terms of reducing institutional perinatal mortality rate, now standing at around 15, with a lot of progress made in reducing the fresh stillbirth rate. And I've brought out this message clearly to show to us that we are collectively looking at every baby's life, right from conception up to the first month of life. We need to see that no baby is born dead and no baby dies within the first month of life. And our collective effort is to see that all these babies are saved and we bring an end to all the preventable causes of death. I'll start off with sharing some of the evidence that points to impact on scaling up level 2 care. And like we can see in this slide, we save babies' lives right from preconception, during antenatal care, during labor and delivery, the care for every baby, but also the care for the small and sick newborn. And you can see from the blue bars that we have significant babies that can be saved by just scaling up the care of the small and sick newborn. And this is where we have the greatest impact. We know, of course, care around time of birth, which looks at intrapartum care and neonatal resuscitation, has the potential to avert both early neonatal deaths, but also lives for the mother. But we can also achieve greater milestones if we are able to scale up inpatient care for the small and sick newborn. And this speaks to the level 2 care, as we shall see, and including kangaroo mother care and provision of continuous positive airway pressure, CPAP. And like what Dr. Kathy has mentioned, these are evidences that have been shared, and it's our collective effort to see that we are able, as a country, to see that each baby who needs these interventions is able to access them. So when we look at inpatient care for the small and sick newborn, it's not a standalone. Saving a baby's life starts from before conception, preconception. And that time, from birth up to 28 days, is just part of the entire continuum of saving a baby's life within the woman's and children's health. And this is what we are trying to demonstrate here. So right from preconception, at both community level, primary health care level, and tertiary care, we are able to have interventions that contribute to the life of the mother and the life of the baby. And going through the entire continuum of care up to when the child has gone beyond the 28 days. the component we are discussing today and what this panel is going to focus on, which is the inpatient care at both the primary health service points and the tertiary points, is just part of a broader picture. And for us to build a system of newborn care as a country, we need to look at all these pieces together. We know that, for example, maternal well-being, maternal nutrition, the quality of intrapartum care greatly contribute a lot to newborn survival. And this is the picture, this is the message that we need to take out. Let's not think about newborn survival as those interventions that happen immediate after birth. Let's not look at newborn survival as just neonatal resuscitation or providing KMC, but right from antenatal care, right during intrapartum care, the monitoring. Yesterday we saw the commissioner presenting about the decision to incision time having a great impact on the outcome of the newborn. So we are able to either make our babies survive or not survive even before they come to life. And this is evidence that we are sharing today. And again, Dr. Kathy has gone through this WHO model of small and sick newborn care, and I'm glad she has shared with us the content of care, which basically looks at the evidence-based practices we are going to do. My task today will be to look at the other side of what we need as a system to scale up. You know, we have the evidence-based practices that have been shared: kangaroo mother care, CPAP, inpatient care, capacity building. But in terms of the components that have been documented that we need to adopt as a country, these are the 10 models which we shall discuss in my presentation. And the first is of an enabling environment, the policies, the guidelines. We need to have a plan, and I'm happy to report that this is part of the work that we've been able to do. As a country, we need to know what we are going to do and in which period of time. And this is what we have as evidence one. So evidence two is the financing. We know, for example, that putting all these pieces together to provide newborn care, the human resource we need, the infrastructure we need, the commodities we need requires financing. We need to advocate as key stakeholders in newborn care for more funding and more financing for newborn health. We know, as we've seen from the data, that newborn deaths are now the leading causes of deaths within our facilities as a country. And we cannot continue doing business as usual. We need to do more. And part of this talks about funding and financing, both from government, but also from all our partners in this house. We've seen the evidence that the expert has shared with us, but now we need to collectively come together to see that this is scaled up to every baby who needs it. And the other one is human resource. Talking about human resource, we are talking about having the right HR for newborn, who are skilled and knowledgeable to provide newborn care, but also the right numbers and equitable distribution. We have over 141 districts in the country. We need to see that we have the right human resource in every country where there's every baby at all levels of care in our country. And then the infrastructure and designs. This is an evidence that we need to look at as a country. We have worked together collectively with the infrastructure department and other stakeholders to see that we come up with standardized designs and infrastructure for newborn care. So this is an evidence that is very key in scaling up newborn care across the different districts. And we are happy that, and we are requesting every stakeholder to come and support these efforts to see that once we have these standardized, we follow these for every baby to receive adequate care. And then equipment and commodities, I cannot overemphasize this, including the innovations, the evidence-based interventions that have been mentioned out, the CPAP, which is a key intervention for level 2 care, the medical commodities, including some of the core, the critical commodities for newborn, like caffeine citrate, surfactant. All these are very important if you are to talk about scaling up newborn care. And then ensuring that you have a very robust health information system right from the patient level up to program level. We have to have the ability to ensure that you have data for newborn collected and utilized at all levels, including patient level data, aggregate data, and the most important thing is for us to be able, at all our levels, right from the neonatal units up to the districts and the Ministry of Health, this information you are collecting about newborn should be able to be utilized and decisions made to improve care. The other important one is the linkage to maternal health, similar to what I've mentioned in my previous slide. We cannot save newborns as standalone without saving the mother. We know, for example, that birth asphyxia is the leading cause of newborn mortality. There's nothing much we can do about this if, again, we don't intervene from the maternal side. So for us to be able to design systems in our facilities as a country to reduce newborn mortality, we have to start from the maternal side. And that is very important. And then family and community. Newborn survival does not only end in our facilities or does not start from our facilities. There's need for us collectively as stakeholders for newborn care to build robust systems for community programs, newborn follow-up, but ensuring that also families are part of newborn survival. Very many babies are cared for in our facilities, but what happens after discharge? We need to see that we have a system that can be able to identify and follow up these babies to the facilities. And then finally, still linked to the communities, the post-discharge follow-up to ensure continuity of care. So again, just mentioning about the evidence, we know at the different levels, right from the basic to the secondary and the tertiary levels, what type of care should be provided and the interventions at the different levels. And this is not a standalone. This builds on the entire health system, our health it is. We know, for example, right from community level up to our tertiary level, we have mothers and newborns in the continuum of care. So right from the antenatal care, intrapartum care, and immediate care after every baby is born, we have services that should be provided at each level. Essential newborn care, very key for every baby. We've seen the evidence that it also reduces a significant number of deaths in this deaths happening among babies. Provision of KMC, skin-to-skin care, immediate breastfeeding, very important, including neonatal resuscitation. So neonatal resuscitation is very important, especially as we are battling with asphyxia in this country. But most important also, the quality of intrapartum care. Then looking at the secondary level, and I will again break down this, we have to provide continuous warmth for these very sick babies, but also scaling it up for airway support to provide continuous positive air pressure, among other factors. And then advanced care, where we look at more complicated cases, looking at mechanical ventilation, assisted feeding, among others. So this evidence is there, like what, again, Dr. Kathy has presented. And the task for everyone here in this room is to see how we are able to bring out this. So putting that in context, I will just share with you what, as a country, what as Ministry of Health and the newborn stakeholders have agreed as our neonatal unit standards, based on that evidence that we know. We have agreed as a country that our care for newborns should be provided within 5 levels, reflecting the different service points we have, reflecting the different levels we have, right from health center 3s, where we expect to provide BMOC services. Here we expect to have a level 1 newborn care, mainly tasked with ensuring that you have stable babies, but also providing essential newborn care and neonatal resuscitation, but also the ability to identify sick babies, stabilize, and refer. So our level 2, which is the discussion for this morning, we have 2 sub-levels, that is level 2A and level 2B. And again, to fit within our health system and the structure, we are looking at level 2A being at the health center 4s, where we have the first special care units for babies. We expect to admit babies here, babies who need immediate attention, but also who are not advanced in terms of respiratory support. And then level 2B at general hospitals, babies who need additional respiratory support, including CPAP. We have level 3 at the regional referral hospitals, which we are calling the neonatal intensive care unit, which will look at having, we have level 2B is the high dependence unit, and then level 3 is the neonatal intensive care unit, looking at managing very sick babies who need intensive care and respiratory support, advanced respiratory support, including mechanical ventilation, in addition other support systems. And then level 4, the super specialized, including neonatal surgeries and more advanced care. So this is the framework under which we are calling upon all stakeholders to scale up and implement newborn care based on the evidence that we've shared with us. And we're hopeful that moving together with you, we are able to avert the deaths that we all want to reduce. So again, this is part of what I've discussed. And again, the recommended services, like we've said, are linked to the services that the health system is able to provide. And like we have seen, this newborn is not a standalone. We are fitting within the health system, and whatever services that make up the entire health system, right from the human resource to the essential commodities to the equipment that fit within our health system, is what we want these newborns to be based on. So based on that, on those standards, we are able to undertake and the functionality status to try and understand how we stand as a country in terms of these levels, in terms of the level 2 particularly. We've seen the evidence that this inpatient care can dramatically avert our neonatal deaths. But where we stand currently, we are able to undertake an assessment of all CMOC facilities in the country, public CMOC facilities, around 282 facilities, to try and understand where we have neonatal units and their functionality status. And of all the 282 facilities that were assessed, only 178, reflecting around 63%, had a neonatal unit, what we call a neonatal unit, space designated for newborn care. However, only 104% of these units, which is around 37, were fully functional, all operational. So this is still a big gap, despite the fact that we've made tremendous progress, but we have only 37% functional neonatal units in the country. And of course, there are other still challenges across these units, including the spaces that define the level 2, the triaging area being at around 42%, the KMC area being around 63%. So this is still a big challenge, and a call upon everyone to see that we keep supporting this. And again, for the different levels, for the health center 4s, you can see that that's where we have the lowest functionality status. At only 20.9% of all center 4s have functional neonatal units. And then general hospitals being at 73.7, and then our regional and national referral hospitals all having neonatal units. And overall at the national levels, we are standing at, like I've said, 63.9% functional. However, for those with neonatal units, that is at around 63.1. So we are looking at this availability of services in two angles. We have facilities which have units. We have facilities which have units and are fully functional. So our gap is to, first of all, ensure that everyone who has a facility, it is made fully operational and functional to provide newborn services, but also reaching out to those facilities that don't have space for newborn care services. So, and these are some of the key challenges that, again, we want to talk about. Again, workforce, HRF for newborn, talking about the numbers, the equitable deployment, For example, we have around 5 neonatologists in the country, but majority of them are based in Kampala. We need to be in a situation where all regions have equitable HR. And then the nurses, which are very critical. Dr. Kathy has just shared to us about the in-service natal nursing training. We have only managed to train 192, but we need more. We need all these units to be equipped with skilled human resource for newborn. Infrastructure gaps, still a very big challenge, where we have space and equipment, and then supply chain, critical commodities. We have just revised our essential medicines list to include caffeine citrate up to general hospitals. We know this is a commodity that is needed both in prevention of apnea of prematurity and management. It means we need it in every facility where the baby is born, where a preterm is born. Surfactant is only available up to the regional referral hospitals. However, even where the availability has been made in the policy environment, sometimes we are challenged with stockouts, and then data for newborn. For so many times, the newborn data has been just part of the mother, either on the mother's chart, no newborn register, very well known. Birth asphyxia, still a very big challenge. Prematurity and neonatal sepsis. Yesterday, from the report, we saw a very high number of low birth weights, even who are not 50% of our babies born with low birth weight are term babies. So it is coming out as a challenge on its own. We're having very many babies born to mothers who are term and are low birth weight. So we need to see how we intervene from the mother's side. And then the access challenges, the geographical access, the community gaps we've mentioned, the lost follow-up. We have these babies born preterm, but we are unable to follow up in their community. So in terms of what Minister of Health has done and is doing, we are looking at this at a multi-level approach from both the national level, where we are doing at the newborn working group has been set up under the Reproductive and Child Health Department to oversee and manage newborn work in the country, but coordinating with the National Referral Hospital and also the partners and all stakeholders to ensure that we coordinate newborn work. And then at the regional referral level through the local maternity and neonatal systems, we are ensuring that we conduct and oversee newborn work, including regional mentorships, learning networks to be able to see that one region is able to share with another, but also create a network of care, newborn network of care within regions. And then districts, like we've seen the levels, working with the district health offices, ensuring that we have health facilities take lead on newborn care, and community where we have both the VHTs and the CHUs, to see that we have a robust system of following up these babies, but also identifying babies who need referral. And all these are hinged among the policies and guidelines and the different strategies that we have come up with. The reproductive and maternal sharpened plan has prioritized newborn care, which again has informed the essential maternal and newborn care guidelines, the newborn clinical care protocols. We have the child survival strategy, the newborn implementation plan, which is giving us a 5-year approach on how we are going to handle the issue of newborn survival for the next 5 years. And then the ICCM strategy and the community health strategy, which we are hopeful we shall be able to use to guide our implementation for the community. And then finally, like I've mentioned, this is a multi-pronged approach. We cannot avert newborn mortality with just one single intervention. There's no one magical bullet that can really bring down these deaths, except if we address all the challenges, like we've mentioned, and using an integrated approach right from the maternal side. And this is what we've done as Minister of Health and as the Reproductive and Child Health Department, working together with all the stakeholders in this room to ensure that we are able to create those facility linkages, to address issues of infrastructure and equipment, the evidence-based practices, the building health workforce capacity from both pre-service and in-service. And we're happy to report that this year, again, we're able to approve the neonatal fellowship program for this country to be able to train neonatologists within Uganda here. Our first cohort will be graduating but we also have taken another cohort, and we are hopeful that this eventually will build up in required numbers for having neonatologists. But also in service, we are doing the comprehensive in-service training and mentorships, and focusing also on issues of data, partnerships, and mobilization, very important. We need everyone to move with us to see that we address newborn mortality and survival. Thank you very much. I want to appreciate the moderator and everyone and all of you for the work. I know we've done this with everyone. Thank you very much.